This is an AI-generated podcast based on a chapter in the book Gastroenterology Clinical Focus by Dr. Emad Qayed. We hope this podcast helps you strengthen your understanding of gastroenterology. Please like, subscribe, and share this channel with colleagues and students who might find it useful.
Today, we're really plunging headfirst into gastroduodenal disorders, and we're focusing specifically on the stomach. Okay, let's unpack this straight away, starting with something really common and, frankly, often miserable for patients, when the stomach just slows right down.
Gastroparesis, the dreaded stomach slowdown, as you called it. So technically, it's delayed gastric emptying, but crucially, without any kind of mechanical blockage.
Right, no physical obstruction.
And when we look at why it happens, the etiology, we generally think about three main buckets, three major groups.
These are the classic causes, I suppose, but the details within them are pretty revealing.
For sure. First up, there's idiopathic gastroparesis. This is the most common form, maybe up to half of all cases.
And the demographics there are striking.
They really are. About 90% of these patients are women. And there's a very, very strong link with underlying anxiety and depression. It really points towards a significant mind-gut connection, in the pathophysiology.
Okay, that's idiopathic. What's the second major cause?
Diabetic gastroparesis. And the stats here really underscore how severe nerve damage from poor glycemic control can be. Over a 10-year period, the risk of developing gastroparesis is estimated at 5.2% in type 1 diabetes.
Wow, that's quite high.
It is, and significantly higher than the roughly 1% risk you see in type 2 diabetics. It just highlights the impact of, the duration and intensity of nerve damage.
And the third classic category, post-surgical causes.
Right. Usually after major upper GI surgeries, things like a Whipple procedure or maybe a vagotomy, which used to be done more often for complex ulcers.
Because these procedures can actually damage the nerves controlling the stomach.
Exactly. They can sever those neural pathways that regulate gastric motility. It's interesting, though, even things like laparoscopic fundoplication for reflux can sometimes cause temporary symptoms.
Oh, really?
Yeah, but the good news there is that symptoms usually resolve in over 90% of those patients, typically within about a year.
Okay, so those are the big three. But here's where things get really, really topical now. Medication-induced gastroparesis.
Ah, yes. This has exploded into view recently.
Especially with the GLP-1 agonists, medications like semaglutide, exenatide, liraglutide. They're everywhere.
They are, and they're critical drugs for diabetes and obesity management, no question. But their mechanism of action is to slow down gastric emptying. That's how they promote satiety.
It's part of how they work.
It's a deliberate pharmacological effect. But in certain individuals, maybe those predisposed, it can tip over into actual clinical gastroparesis.
So it's not just the GLP-1s we need to think about.
Oh, absolutely not. We always have to screen for the usual suspects in anyone presenting with symptoms of slow emptying. Opioids are a big one, tramadol too.
TCAs.
Tricyclic antidepressants, definitely. And anticholinergic drugs. Basically, a really thorough medication review is mandatory before you even think about ordering fancy tests.
Makes sense. Okay, so let's say we suspect gastroparesis. Moving to diagnosis, the guidelines are pretty strict here, aren't they? You can't just diagnose it based on symptoms alone.
Correct. Symptoms like nausea, vomiting, early satiety, bloating, they're incredibly nonspecific. They overlap with so many other conditions.
So we need objective proof, the gold standard test.
That's the scintigraphic gastric emptying study, or SGE, and it has to be done with a standardized meal, typically a low-fat solid meal like the egg white meal you mentioned.
And the critical detail, the one that often trips people up.
It's the timing. You must measure the retention directly at the 4-hour mark.
Not earlier, like at 2 hours.
No. You can't just extrapolate from 2 hours. Many patients might look okay early on, maybe normal emptying at 1 or 2 hours, but they fail to fully empty by that crucial 4-hour point.
And that 4-hour number, the percentage of the meal still left in the stomach, that dictates everything else.
Pretty much. It gives us the severity grading, which then guides the treatment approach.
How does that grading work?
So mild gastroparesis is defined as 11 to 20% retention at 4 hours. Moderate is 21 to 35%. Severe is 36 to 50%.
And above 50%.
That's classified as very severe.
Okay. So SGE is the benchmark. Are there any alternatives?
There are. The guidelines do approve 2 others. The wireless motility capsule, sometimes called the SMART pill, and stable isotope breath testing.
but they're not used as often.
Generally less available, maybe less familiar to clinicians, and sometimes harder to get reimbursed for compared to the standard SGE. So SGE really remains the workhorse.
All right, diagnosis confirmed. Now, treatment. This feels like walking a tightrope.
It often is. The first step is always dietary modification. Small, frequent meals. Low in fat, low in fiber or residue.
And in diabetics.
Absolute optimization of glycemic control is paramount. That alone can sometimes improve symptoms. But when medication is needed, the risk-benefit calculation becomes really critical, starting with the only FDA-approved drug.
Metoclopramide.
Metoclopramide,
Right.
but its use is heavily restricted. The FDA approval is only for short-term use, less than 12 weeks.
Because of the black box warning. Tardive dyskinesia, TD.
Exactly. That warning about the risk of potentially permanent involuntary movements has historically made clinicians very wary.
Understandably so. Has our understanding of that risk changed at all?
It's been refined, I'd say. TD is definitely a real risk. It's more common with longer use over 3 months and seems to affect elderly females more often. But some recent meta-analyses have sort of put the absolute risk into better perspective. It seems much lower than the initial high estimates, maybe less than 1%, perhaps even as low as 0.1 per 1,000 patient years.
So not zero risk, but maybe not as high as previously feared.
Right. The reframing suggests that for patients with really severe symptoms, a limited, carefully monitored course of metoclopramide, using the minimal effective dose, might be reasonable. But the guideline is firm. If you don't see a clear symptomatic response within those first 3 months, you absolutely must stop the drug. No pushing it.
Okay. What about domperidone? It often comes up as maybe a theoretically better option because it doesn't cross the blood-brain barrier as much.
That's its main advantage. Domperidone is a peripheral dopamine D2 antagonist. It stimulates gut contractions pretty effectively, but because it doesn't readily get into the brain, you avoid most of the central nervous system side effects like drowsiness or dystonia that you can get with metoclopramide.
Sounds good. What's the catch?
The catch shifts to the heart. Domperidone carries a significant risk of QT interval prolongation on the EKG, which can predispose to serious ventricular arrhythmias.
So cardiac monitoring is essential.
Absolutely critical. You need a baseline EKG before starting and repeat EKGs during treatment to monitor that QT interval. And of course, for anyone listening in the US,
It's not available through regular pharmacies.
correct. You can only get it through a special FDA investigational drug clearance process, which is a major hurdle for routine clinical use.
Okay. Then there's erythromycin, the antibiotic.
Yeah.
Used off-label as a prokinetic.
Yes, erythromycin acts as a motilin receptor agonist. Motilin is a natural hormone that stimulates powerful antral contractions, kind of like a cleanup wave in the stomach. Erythromycin mimics that.
But it has a major downside too, right?
Tachyphylaxis. Its effectiveness wears off pretty quickly, often within just a few weeks. The receptors just seem to downregulate.
So it's not a long-term solution.
Definitely not. Some clinicians try to work around it by cycling the medication maybe 3 weeks on, 1 week off to try and maintain responsiveness. But it's really best for short-term boosts, maybe during an acute flare.
It's also important to mention things that have been tried and clearly shown not to work, right? To guide people away from ineffective therapies, like TCAs.
Yes, the NORIG trial was a big one. It looked at nortriptyline, a TCA, for idiopathic gastroparesis. The result was definitive. It was not effective for improving the core symptoms.
And what about injecting Botox into the pylorus? That sounds like it should work, relaxing the stomach outlet.
It sounds logical, doesn't it? Intrapyloric botulinum toxin injection, or BTI. But randomized controlled trials, good quality RCTs, showed it was no better than injecting placebo, at least in patients who weren't already refractory to other treatments.
So not routinely recommended.
Generally avoided, exactly. Unless you're in a really difficult refractory situation, maybe as part of a specialized center's approach, but it's not standard care.
Okay, so this brings us to the real cutting edge. The more invasive options reserved for the toughest cases. GPOM.
GPOM, gastric peroral endoscopic myotomy. This is a really innovative endoscopic procedure.
How does it work?
The endoscopist basically creates a tunnel within the stomach wall, under the mucosal layer. They tunnel down to the pylorus muscle, that ring of muscle at the stomach outlet. And then, using specialized endoscopic tools, they cut the pylorus muscle, perform a myotomy from the inside. It essentially creates a permanent, non-surgical pyloroplasty, widens the outlet.
And the evidence for this? It's still relatively new.
It is, but the initial data, particularly from small sham-controlled trials, has been quite promising. One key trial showed something like a 71% success rate with GPM, compared to only 22% in the sham group who had a fake procedure.
That's a significant difference.
It is. But given its invasiveness and the skill required, the AGA recommendation is very clear and strict. GPM should only be considered for patients with truly refractory gastroparesis.
Meaning they've failed standard medical therapy for how long?
For at least 6 to 12 months, it's really positioned as a last resort for medical failures, not something you jump to early on.
Well, let's pivot now to functional disorders, where things are, well, often violently rapid, starting with cyclic vomiting syndrome, CVS.
Right, CVS. This is characterized by these really intense recurrent episodes. Severe nausea, vomiting, often abdominal pain too. But the key is that these episodes are separated by periods where the person feels completely fine, totally symptom-free.
And the diagnosis relies on strict criteria.
Yes. The Rome-Brevi diagnostic criteria are essential here. First, the episodes have to be stereotypical, meaning they tend to be very similar each time for that individual, starting and ending abruptly. Second, each episode usually lasts less than a week. Third, they need to have had 3 or more of these distinct episodes within the past year.
And they have to be separated in time.
Yes, occurring at least 1 week apart, crucially with those symptom-free intervals in between. We often talk about the phases: the prodrome, where they might feel it coming on, the intense emetic phase, and then the recovery phase.
Now, with the rise in cannabis use, there's a critical mimic we need to differentiate this from: cannabinoid hyperemesis syndrome, CHS.
Absolutely crucial differential. CHS is directly linked to chronic, usually heavy, often daily marijuana use.
And it presents just like CVS.
It can perfectly mimic the cyclic nausea and vomiting of CVS, which is why it gets missed or misdiagnosed so often. The only way CHS gets better is with complete and total cessation of all cannabis use.
Is there any clue clinically that points more towards CHS?
There's one very specific, almost pathognomonic behavioral clue: pathologic bathing behavior. Patients with CHS often discover that taking extremely hot showers or baths gives them temporary relief from the intense nausea and pain.
Why hot baths?
The theory is the intense heat somehow modulates visceral pain signals, maybe through TRPV1 receptors in the skin. But finding someone who spends hours and hours in hot showers during episodes, that strongly suggests CHS.
So the diagnostic test is essentially stopping cannabis.
Pretty much. The gold standard is usually considered 6 months of complete cannabis abstinence. If the symptoms persist despite that, then you're likely dealing with true CVS.
Okay. So for confirmed CVS, how do we manage it? It seems like there are 2 phases: the acute crisis and preventing future episodes.
Exactly. During an acute episode, management is supportive but aggressive. Vigorous IV hydration is key. Antiemetics, often multiple classes used together. Sometimes anxiolytics like lorazepam can help break the cycle. Some even use abortive migraine therapies like triptans, suggesting a link to migraine pathways.
And preventing the next episode: inter-episode prophylaxis.
For prophylaxis, we often borrow from migraine prevention strategies again, things like beta blockers, particularly propranolol, or low-dose tricyclic antidepressants like amitriptyline. Some anticonvulsants like zonisamide or topiramate are also used.
Behavioral factors play a role too.
Huge role. Maintaining rigorous sleep hygiene, identifying and avoiding triggers, managing stress. These are all cornerstone non-pharmacological approaches. #3 rumination syndrome.
Okay, one more in this functional cluster before we move on. Rumination syndrome. I suspect this one gets misdiagnosed all the time.
I guarantee it does. It's often labeled as refractory GERD or maybe difficult to treat vomiting, but it's fundamentally different.
How's it defined?
Rumination is the effortless, almost habitual regurgitation of recently eaten food, usually undigested food. It typically happens quite soon after eating, maybe 10 to 15 minutes.
And the key difference from vomiting or reflux?
Crucially, it happens without the typical preceding nausea or the forceful retching you see in vomiting. And often without that acidic taste of GR, it's more like the food just comes back up easily.
And the underlying mechanism isn't reflux, it's actually a learned physical maneuver.
That's exactly right. It's not passive like GERD. It's thought to be a learned, albeit subconscious, behavioral response. Physiologically, it involves a coordinated action, contraction of the muscles in the chest wall and abdomen.
Increasing pressure in the stomach.
Exactly. Combined with a simultaneous relaxation of the diaphragm. This coordinated squeeze essentially pushes the stomach contents back up the esophagus.
So if the problem is a learned behavior, the treatment isn't really medication, is it?
Primarily, no. The cornerstone of treatment is behavioral therapy, specifically focused on diaphragmatic breathing, or DB.
How does diaphragmatic breathing help?
The goal is to teach the patient a breathing pattern that is physically incompatible with the muscle contractions that cause rumination. You're consciously engaging the diaphragm in a way that prevents that abdominal squeeze.
Are there specific instructions for that?
Yes, very specific. We teach them to inhale slowly through the nose, focusing on making the belly expand outward, filling the abdomen with air. Then exhale slowly through the mouth, letting the belly fall back or retract.
And they need to practice this regularly.
Critically, they need to practice it for about 5 minutes before each meal, and again for 5 minutes after each meal. The idea is to consciously interrupt that learned regurgitation response right around the time it usually occurs.
What about medication? Is there any role?
Really, only for patients who are truly refractory to intensive behavioral therapy. In those select cases, sometimes a medication like baclofen, which is a muscle relaxant, is tried. But behavioral therapy is absolutely the first-line approach.
Okay, let's shift gears now to dyspepsia. This is just such a broad term, isn't it? Basically, pain or discomfort centered in the upper abdomen.
It is incredibly common, and it's an area where we've seen probably the most significant practice-changing guideline shifts in recent years, things that really force clinicians to rethink their approach.
So dyspepsia covers a lot. How do we break it down?
Fundamentally, we divide it into organic dyspepsia, where there's an identifiable cause, like an ulcer, GERD, or even cancer and functional dyspepsia, or FD.
FD being dyspepsia, where after investigation, we find no structural or biochemical explanation.
Exactly. And the Rome 5E criteria help us subdivide FD even further into 2 main subtypes based on the predominant symptoms.
Which are?
There's postprandial distress syndrome, PDS. The main features here are bothersome fullness after meals or feeling full really quickly, what we call early satiety.
And the other type?
The gastric pain syndrome, or EPS. Here, the dominant symptom is actual pain or a burning sensation in the epigastrium. This pain might be related to meals, but often it can occur even when fasting.
Okay, now the big guideline change you mentioned, the one from the ACG and CAG back in 2017 that really stirred the pot.
Yeah.
It's about the age for endoscopy, right?
That was the bombshell, yes. The recommended age threshold for performing an upper endoscopy, an EGD, in patients presenting with new onset, uninvestigated dyspepsia was raised.
From what age to what age?
It shifted from age 55 up to age 60. So now the standard recommendation is EGD for patients with new dyspepsia who are 60 years or older.
But here's the really controversial part, the part that felt counterintuitive to many.
Right. For patients under the age of 60, the guideline now recommends against routinely performing an EGD, even if they have traditional alarm features.
Wait, even with alarm features, like unintentional weight loss, persistent vomiting, difficulty swallowing, anemia.
Correct. Even with those features, in patients under 60, routine EGD is not recommended as the initial step.
That seems risky. How do the guidelines justify ignoring those classic warning signs in, say, a 58-year-old?
It really boils down to a population-level risk assessment and resource utilization argument. The data suggests that in the general U.S. population under age 60, the actual risk of finding an upper GI malignancy, even when alarm features are present, is extremely low. It's less than 1%. So the guideline writers essentially concluded that the costs, the risks, the invasiveness, and the limited availability of endoscopy don't justify scoping everyone under 60, given that very low yield for cancer.
It's a numbers game, basically.
From a public health perspective, yes, though it certainly feels uncomfortable clinically sometimes.
Okay, so if you have a patient under 60 with new dyspepsia, and you're not supposed to scope them right away, what is the recommended pathway?
It's a clear 3-step medical management algorithm. Step 1, you absolutely must test for H. pylori infection using a non-invasive test like a breath test or a stool antigen test. And if it's positive, you treat it.
Test and treat for H. pylori. What's step 2?
If the H. pylori test is negative, or if they were treated but their dyspepsia symptoms persist, then step 2 is an empiric trial of a proton pump inhibitor, a PPI.
For how long? And what dose?
Typically a standard once-daily dose for 4 weeks. It's worth noting the guidelines specifically mention there's generally no added benefit for symptom control in functional dyspepsia by going to twice-daily PPI dosing.
Okay. H. pylori negative, PPI trial done. What if they still have symptoms after those 4 weeks?
Then and only then, according to this pathway, do you arrive at the diagnosis of functional dyspepsia. Step 3 is to treat it as FD using other strategies.
Like what?
Things like tricyclic antidepressants, certain prokinetic agents maybe, or even psychological therapies like cognitive behavioral therapy or hypnotherapy.
You mentioned earlier that actually sticking to this guideline, not scoping the under 60s with alarm features, is hard for clinicians. Why is that?
I think there are two main reasons. One is clinical comfort. It just feels wrong to ignore things like weight loss or anemia without looking. The second is patient reassurance. It's often very difficult to definitively tell a patient you have a functional disorder, there's nothing physically wrong, without the objective evidence of a negative EGD. That negative scope provides huge psychological reassurance for both the patient and the doctor, allowing them to accept the FD diagnosis and move on to appropriate treatments.
Yeah, I can see that. Let's talk about those FD treatments specifically. PPIs offer some benefit.
They do, but it's modest. They seem to work best if the patient's functional dyspepsia symptoms lean more towards reflux-like symptoms, like burning. The number needed to treat, the NNT, is around 10, so you need to treat 10 patients for one to get significant benefit.
And what about eradicating H. pylori, even if they don't have an ulcer, just FD? Does that help?
Surprisingly, yes. There's a small but statistically significant benefit. The NNT there is about 14. So again, not a massive effect, but real enough that it supports the test and treat strategy up front.
Okay. What about using antidepressants? There was a big trial looking at this, wasn't there? The FDTT trial?
Yes, the functional dyspepsia treatment trial. That was a landmark study. It provided really valuable insights.
What did it find?
It showed that amitriptyline, a TCA, used at a dose of 50 milligrams at night, was genuinely beneficial for FD. The response rate was about 53% with amitriptyline versus only 40% with placebo.
Did it work better for certain types of FD?
Yes. The benefit seemed strongest in patients with the epigastric pain syndrome subtype, the more ulcer-like pain. Interestingly, it also found that patients who had underlying delayed gastric emptying, sort of overlapping with gastroparesis, were less likely to respond to the amitriptyline.
Did it test any other antidepressants?
It also tested escitalopram, which is an SSRI, and the finding there was negative. Escitalopram was not superior to placebo for functional dyspepsia symptoms.
So TCA seem better than SSRIs for FD. Are there other agents people use, maybe things that help the stomach relax?
Yes, we sometimes look at agents that improve gastric accommodation. That's the stomach's ability to relax and stretch to accept a meal without causing discomfort.
Like what?
Buspirone is one. It's a 5-HT1A receptor agonist, typically used for anxiety, but it has this effect on stomach relaxation. Mirtazapine, another antidepressant, is sometimes used too.
Why mirtazapine?
It can improve FD symptoms, but it also often causes sedation and weight gain, which can actually be beneficial for some FD patients who are losing weight due to poor intake.
Any non-drug approaches showing promise?
Acupuncture, actually. There have been some good quality trials showing significant benefit from acupuncture, particularly for the postprandial distress syndrome, PDS subtype, the fullness and early satiety. Likely works through modulating the gut-brain axis, #5, Helicobacter pylori, the carcinogen.
Okay, this leads us perfectly into the bug that underlies so many of these issues. Helicobacter pylori. Its importance really can't be overstated, can it?
Absolutely not. H. pylori is classified by the World Health Organization as a Class 1 carcinogen, meaning it's a definite cause of cancer in humans, specifically gastric cancer.
And getting rid of it actually reduces that cancer risk.
Significantly. Meta-analyses consistently show that successfully eradicating H. pylori reduces the subsequent risk of developing gastric cancer. The incidence rate ratio drops to about 0.54, so nearly halving the risk.
So it's not just about healing ulcers anymore.
Right.
Who absolutely needs to be tested for H. pylori?
The list is long. Anyone with active peptic ulcer disease or a past history of PUD. Anyone with gastric malt lymphoma. Patients starting long-term NSAI therapy. Patients on chronic PPI therapy.
Why chronic PPI users?
Because PPIs reduce stomach acid, which can allow H. pylori to potentially migrate higher up in the stomach, possibly increasing the risk of corpus predominant gastritis, which is more strongly linked to cancer. Also, anyone with unexplained iron deficiency anemia, anyone with immune thrombocytopenic purpura, ITP, and importantly, asymptomatic people who have a first-degree relative, a parent, sibling, or child diagnosed with gastric cancer.
Okay, quite a broad range. Now, we're going to test. There's that absolutely critical step beforehand to ensure accuracy.
This is fundamental, cannot be skipped. The patient must be off all PPIs for at least 2 weeks before any active H. pylori testing is done.
Why 2 weeks?
Because PPIs suppress the bacteria. They don't kill it, but they reduce the bacterial load enough that tests which rely on detecting active bacteria like the breath test or stool antigen test can give a false negative result. You might miss an active infection.
Okay, PPI's off for 2 weeks. What about H2 blockers or antacids?
H2 blockers should ideally be stopped for maybe 24-48 hours before. Antacids are generally okay, but PPIs are the big one, 2 weeks off minimum.
All right. What are the best active tests then?
The urea breath test, or UBT, is excellent. It's highly sensitive and specific.
How does that work again?
H. pylori produces a large amount of an enzyme called urease. The test involves swallowing a capsule containing urea labeled with a harmless carbon isotope, either C13, non-radioactive, or C14, very low radiation. If H. pylori is present, its urease breaks down the labeled urea, releasing carbon dioxide tagged with that isotope, which is then absorbed into the bloodstream and exhaled in the breath where we can detect it.
Clever. What about stool testing?
The H. pylori stool antigen test is also very good, nearly as accurate as the UBT, and sometimes more convenient or cheaper. Just make sure you're using a monoclonal antibody-based test, as those are more accurate than the older polyclonal ones.
Yeah, if you're doing an endoscopy anyway, biopsies.
If EGD is being done, then biopsies are the way to go. The current AGA recommendation is to use the 5-biopsy Sydney protocol.
Not just 1 or 2 biopsies.
No, taking 5 biopsies from specific locations, 2 from the antrum, 2 from the body, and 1 from the incisura significantly increases the yield for detecting H. pylori, especially if the infection is patchy. It also allows assessment for atrophy and intestinal metaplasia.
Okay, let's say we diagnose H. pylori and treat it. Is confirming eradication necessary?
Absolutely mandatory. Especially now with rising rates of antibiotic resistance, particularly to clarithromycin, you cannot assume the treatment worked.
And when should that confirmation test be done?
It must be done at least 4 weeks after the completion of antibiotic therapy. And crucially, the patient needs to have been off PPIs again for at least 2 weeks before this confirmation test.
Same rule applies. And which test should be used for confirmation?
You must use an active test again, either the urea breath test or the stool antigen test.
Not blood antibody test.
It's definitely not serology for confirming eradication. H. pylori antibodies can remain positive in the blood for months, even years, after the infection is completely gone. So a positive antibody test after treatment tells you nothing about whether the treatment was successful.
That's a really key point. Okay, what about treatment itself? The ACG guidelines were updated relatively recently in 2024. What's the recommended first-line therapy now?
The clear first-line recommendation, especially in North America where clarithromycin resistance is high, is bismuth quadruple therapy.
What does that involve?
It's a 4-drug regimen, a standard dose PPI twice daily, bismuth subsalicylate or subcitrate 4 times daily, tetracycline 4 times daily, and metronidazole 4 times daily.
For how long?
For 14 days. The duration is important. 10 days is often not enough.
That sounds like a lot of pills.
It is demanding, which affects adherence, but it achieves high eradication rates, even in areas with clarithromycin resistance. And importantly, it's suitable even for patients with a penicillin allergy, unlike some other regimens.
What about older regimens like clarithromycin-based triple therapy?
Generally not recommended first line anymore unless you are in a region with known low clarithromycin resistance, less than 15%, and the patient hasn't had prior macrolide exposure. The ACG actually removed some more complex regimens like sequential therapy and concomitant therapy from the main recommendations due to inconsistent results.
Are there any newer options emerging?
Yes. There's rifabutin triple therapy, PPI, amoxicillin, rifabutin, approved for salvage therapy, and therapies using potassium-competitive acid blockers, or PCAs, like vonoprazan, combined with antibiotics, dual or triple therapy, are showing promise and gaining traction, especially in Asia, and now approved in the U.S.
What if that first-line bismuth quadruple therapy fails? What are the usual reasons, and what do we do next?
The overwhelming reasons for failure are either poor adherence to that complex 14-day regimen or antibiotic resistance, particularly to metronidazole or tetracycline in this case.
So what's the approach for refractory cases?
Ideally, the next step involves trying to get antibiotic sensitivity testing, usually via culture from endoscopic biopsies. This can guide the choice of a subsequent salvage regimen. However, you also have to weigh the risks and benefits carefully, especially in, say, a frail elderly patient without a strong indication like PUD or multimphoma. Is the potential benefit of eradication worth subjecting them to another round of powerful antibiotics with the risk of side effects and, importantly, the risk of inducing C. difficile infection? It becomes a very individualized decision.
Okay, before we dive solely into malignancy, let's touch on a rare but really distinct condition, Menetrier's disease.
Menetriers. Yes, it's uncommon but memorable once you see it. It's a disorder characterized by these massively enlarged hypertrophic gastric folds, primarily in the body and fundus of the stomach.
What causes those giant folds?
It's due to a massive overgrowth or hyperplasia of the foveolar cells, the mucus-producing cells in the gastric pits.
And what symptoms does it cause?
Patients often present with abdominal pain, maybe nausea or vomiting. But a key feature is often significant protein loss from the stomach lining, leading to low albumin levels in the blood, which can cause peripheral edema, swelling, and sometimes anemia.
And it carries a cancer risk.
Yes. Importantly, Menetri's disease is considered a premalignant condition, carrying an increased risk of developing gastric adenocarcinoma over time.
What does it look like on endoscopy? Is there a classic appearance?
Absolutely. Endoscopically, you see these incredibly thick, convoluted, almost brain-like folds. But the key finding is the distribution. The giant folds affect the fundus and the body of the stomach, but classically, the antrum is spared. It looks relatively normal.
And diagnosis requires biopsies.
Yes, and you need deep biopsies, maybe even snare biopsies, because the primary pathology that foveolar hyperplasia is deep within the mucosa. Standard forceps biopsies might miss it. Histologically, you see that massive foveolar hyperplasia, and the glands often take on a distorted, elongated appearance, sometimes described as looking like corkscrews.
Is there a specific underlying mechanism we understand now?
Yes, the pathophysiology is much clearer now. It's driven by excessive signaling through a specific pathway involving the receptor tyrosine kinase epidermal growth factor receptor, or RTK-EGFR.
How is that pathway getting activated?
It's usually due to the local overexpression of transforming growth factor alpha, or TGFA, which binds to and activates the EGFR, driving that excessive cell growth.
Does understanding that mechanism offer any treatment options?
It does, thankfully. While supportive care, high-protein diet, managing symptoms is important, we now have targeted therapy. Cetuximab, which is a monoclonal antibody against EGFR, can block that aberrant signaling pathway. Octreotide, a somatostatin analog, can also sometimes help by reducing TGFA levels.
All right, let's move into the territory of premalignancy and malignancy, starting with high gastrin levels, hypergastronemia. This can sometimes be the first clue to a serious underlying condition like Zollinger-Ellison syndrome, ZES.
Exactly. Hypergastronemia, usually defined as a fasting serum gastrin level over, say, 200 pgml, needs investigation. The very first step is to figure out if it's appropriate or inappropriate hypergastronemia.
What's the difference?
Appropriate hypergastronemia means the high gastrin level is a normal physiological response to low stomach acid. The body is trying to stimulate more acid production. You see this commonly with chronic PPI use or in conditions like chronic atrophic gastritis where the acid-producing cells are damaged.
Okay, so the gastrin is high because the acid is low. What's inappropriate hypergastronemia?
That's when the gastrin level is high despite normal or even increased stomach acid production. This is the hallmark of Zollinger-Ellison syndrome.
Which is caused by a tumor.
Yes. ZES is caused by a gastrin-producing tumor called a gastrinoma. These are neuroendocrine tumors, most often found in the pancreas or the wall of the duodenum. They just pump out gastrin autonomously, leading to massive acid hypersecretion.
When should ZES really jump to the top of the list of possibilities? What are the red flags?
You should have a high suspicion for ZES in a few key scenarios. One is recurrent peptic ulcer disease, especially ulcers in unusual locations like the distal duodenum or jejunum. Another is PUD that occurs in someone who is confirmed negative for H. pylori and is not taking NSAIDs, so-called idiopathic PUD. And the third is finding peptic ulcers in combination with very prominent thick gastric folds or rugae on endoscopy, which is a sign of the stomach lining being overstimulated by all that gastrin.
Okay. Diagnosing ZES involves checking acid levels, which means the patient has to stop their PPI. And you mentioned earlier, this is potentially dangerous.
This is probably one of the highest stakes situations in GI diagnostics. If a patient truly has an underlying gastrinoma, stopping their high-dose PPI abruptly can trigger a massive uncontrolled rebound in gastric acid hypersecretion.
Why is it so severe?
Because the gastrinoma has been constantly stimulating the parietal cells in the stomach, causing them to multiply and increase their capacity to make acid trophic effect. The PPI has been holding that acid back. When you suddenly remove the PCI dam, you can get torrential acid production, leading to severe symptoms, rapid ulcer recurrence, bleeding, and even perforation. It can be life-threatening.
So there must be a very specific, safe protocol for withdrawing PPIs before testing for ZES.
Absolutely critical. It needs to be done carefully and methodically. First, you should probably confirm that any existing ulcers have healed, usually with a repeat EGD, before you even start the withdrawal.
Makes sense.
Then, you have to counsel the patient thoroughly about the risks and the plan. The key is to wean the PPI gradually. Don't just stop at cold turkey, maybe reduce the dose over a week or two, then switch them to a high dose of an H2 receptor blocker, like famotidine, for maybe 3 to 5 days. This helps blunt the immediate acid surge, but interferes less with the diagnostic tests.
And then stop the H2 blocker right before the test.
Exactly. Stop the H2 blocker about 24 hours before the planned gastrin level measurement and gastric pH testing. During that final 24-hour window, only simple antacids like calcium carbonate or magnesium hydroxide are allowed for symptom control, as they don't significantly affect the tests.
Okay, PPI safely withdrawn. How do we confirm the ZES diagnosis?
Diagnosis usually requires demonstrating two things simultaneously: a significantly elevated fasting serum gastrin level, often 1,000 pgml, but certainly elevated, and a low gastric pH, typically less than 4, confirming acid hypersecretion.
What if the gastrin level is high, but not astronomically high, maybe in that intermediate range?
That's where the secretin stimulation test comes in. This is considered the definitive diagnostic test for ZES.
How does that work?
You measure a baseline gastrin level, then administer synthetic secretin intravenously. Normally, secretin inhibits gastrin release from normal G cells, but paradoxically, in patients with a gastrinoma, secretin stimulates gastrin release from the tumor cells.
So a positive test...
A positive test is defined as an increase in the serum gastrin level by at least 120 pg/ml over the baseline level, usually within 5 to 10 minutes after the secretin injection.
And once ZES is confirmed, finding the tumor is the next step. Where do they usually hide?
About 80–90% of gastrinomas arise within a specific anatomical region called the gastrinoma triangle.
Defined by?
Its corners are roughly the junction of the cystic duct and common bile duct superiorly, the junction of the second and third portions of the duodenum inferiorly, and the junction of the head and neck of the pancreas medially. So intensive imaging focuses on the duodenum and pancreas.
And there's a link to a genetic syndrome.
Yes, a very strong link to multiple endocrine neoplasia type 1, or MEN1. Somewhere between 30% and 60% of patients with ZES actually have underlying MEN1 syndrome, which also involves parathyroid and pituitary tumors. So screening for MEN1 is crucial in anyone diagnosed with a gastrinoma.
Okay, moving away from ZES, let's talk about gastric polyps. These are found pretty commonly on endoscopy, right? But not all polyps are created equal. Let's start with the most common type: fundic gland polyps, or FGPs.
FGPs are very common, especially now with so many people undergoing endoscopy. They're typically small, maybe 1 to 5 millimeters, usually multiple, and located, as the name suggests, in the fundus and body of the stomach, the acid-producing areas. They look like little smooth bumps.
There used to be a big debate about whether PPIs cause these, didn't there?
There was huge debate for years. But recent, large, well-done systematic reviews and meta-analyses have pretty much put that controversy to rest. They found basically no significant association between chronic PPI use and the development of fundic gland polyps.
So we don't need to worry about PPIs causing them?
Not really, no. The current thinking is they're mostly sporadic or sometimes associated with genetic syndromes like FAP, familial adenomatous polyposis.
Do they need surveillance?
Generally, no. Routine surveillance for small, typical FGPs is not recommended. The risk of them turning into cancer is extremely low. The only time we might worry is if a sporadic FGP is unusually large, say bigger than 1 centimeter. Those should probably be removed and examined.
Okay, so FGPs are mostly benign. What about hyperplastic polyps? Are they different?
Yes, hyperplastic polyps are fundamentally different. They are usually a response to chronic inflammation or damage in the stomach lining.
Caused by what?
Most commonly caused by chronic H. pylori infection or sometimes autoimmune gastritis. You often find them near areas of inflammation like ulcer edges or old surgical sites.
Do these have malignant potential?
They have a slightly increased risk of malignant transformation compared to FGPs, especially if they grow larger, say over 2 centimeters, or if they contain areas of dysplasia. So resection of most hyperplastic polyps is generally recommended. And critically, you must biopsy the surrounding mucosa to check for H. pylori and rule out underlying atrophy or intestinal metaplasia, which is the real driver of inflammation.
Perfect segue. Let's talk about gastric intestinal metaplasia, or IM. This seems like a really crucial point in the pathway towards gastric cancer.
It absolutely is. IM is considered a key step in the multi-step process of gastric carcinogenesis, often referred to as the chorea cascade.
Can you walk us through that cascade?
Sure. It typically starts with chronic inflammation, most often initiated by H. pylori infection. This leads to atrophic gastritis, where the normal stomach glands are lost. The damaged stomach lining then tries to repair itself, but sometimes it repairs abnormally, transforming into tissue that resembles intestinal lining, that's intestinal metaplasia, or IM.
And IM can progress further.
Yes. IM itself can be subtyped into complete type, resembling small intestine, and incomplete type, resembling large intestine. The incomplete type seems to carry a higher risk. From IM, the next step can be dysplasia, which is unequivocally precancerous changes in the cells. And finally, dysplasia can progress to invasive adenocarcinoma.
So intervening early in this cascade is key. What's the most important intervention?
Without a doubt, finding and eradicating H. pylori infection. Successful H. pylori eradication is the only intervention clearly proven to slow down, and potentially even cause regression, of these precancerous changes like atrophy and possibly IM, thereby reducing the long-term cancer risk.
Are there specific factors that identify patients with IM who are at particularly high risk of progressing to cancer?
Yes, several factors significantly increase the risk. A family history of gastric cancer in a first-degree relative is a big one. It increases the risk about 4.5-fold. Pathologically, having the incomplete type of IM carries about a 3-fold higher risk than the complete type. Having multifocal IM, meaning it's found in biopsies from both the antrum and the body of the stomach, roughly doubles the risk compared to focal IM. And of course, persistent ongoing H. pylori infection is a major driver of progression.
Okay, this brings us right to that major area of controversy we hinted at earlier. Surveillance endoscopies for patients found to have IM. The guidelines really differ here, don't they?
They absolutely do. This is one of the starkest examples of conflicting recommendations in GI guidelines globally. It really puts clinicians and patients in a tough spot.
What do the European and British guidelines say?
Guidelines from organizations like the European Society of Gastrointestinal Endoscopy, ESGE, and British Society of Gastroenterology, BSG, are quite clear. They explicitly recommend endoscopic surveillance for patients with intestinal metaplasia, especially those with higher risk factors. The usual interval recommended is every 3 to 5 years.
Okay, so Europe says survey. What about the U.S. guidelines from the AGA?
The most recent AGA guideline on this from 2020 takes a very different stance. It recommends against routine surveillance of gastrointestinal metaplasia in the general U.S. population.
Why the difference?
The AGA's reasoning is based primarily on the lack of strong randomized trial evidence definitively proving that surveillance endoscopy actually improves patient outcomes or reduces gastric cancer mortality in the relatively low incidence U.S. population. They argue the potential harms and costs might outweigh the uncertain benefits for most people.
But they don't completely rule it out.
No, they leave the door slightly open. They suggest that surveillance could be considered for certain high-risk individuals, those with incomplete or extensive IM, or a strong family history, particularly if those patients place a high value on a potential but uncertain reduction in gastric cancer mortality. It basically becomes a shared decision-making process, acknowledging the uncertainty.
So if a patient and doctor do decide to proceed with surveillance, maybe based on those high-risk factors or patient preference, what constitutes a high-quality EGD and biopsy protocol to properly map the IM? You can just take random biopsies.
Quality is absolutely paramount if you're going to do surveillance. First, the EDD itself needs to be meticulous. This means adequate time. A minimum withdrawal time of 7 minutes is often cited. Excellent mucosal visualization with good insufflation, maybe using advanced imaging techniques like narrowband imaging if available. Then the biopsy strategy needs to be systematic mapping. The standard recommendation is, again, the 5-biopsy Sydney protocol, but for IM mapping, it's crucial that the samples are separated into 2 different jars.
Why 2 jars?
One jar should contain the biopsies from the antrum, usually 2, and the incisura, 1. The second jar should contain the biopsies from the gastric body, usually 2 from the lesser and greater curvature.
And this separation tells the pathologist?
It allows the pathologist to report whether the IM is focal, present in only one location, example just the antrum, or multifocal extensive, present in both the antrum incisura and the body. This distinction is critical for risk stratification.
So if surveillance is performed, how often?
If IM is confirmed and deemed high risk, multifocal, incomplete type family history, the usual interval is every 3 to 5 years. However, if the IM is found to be only focal, for example, just in the antrum, and the patient has no other major risk factors, current guidelines generally suggest that no further endoscopic surveillance is needed for the IM itself.
Okay, let's move on to gastric adenocarcinoma itself. Still a major cancer globally, though maybe less common in the U.S. than it once was. Still, it's the 4th most common GI malignancy here.
That's right. And the risk factors are pretty well established now. We've talked about H. pylori being the dominant one. Smoking is a clear risk factor. Obesity increases risk. Prior gastric surgery, especially a Bill Roth II reconstruction, increases risk likely due to chronic bile reflux. And rare conditions like Menetrier disease also predispose.
Are there any classic physical examination signs that might point towards advanced gastric cancer, even manifesting outside the abdomen?
Yes, there are a few well-known eponyms associated with metastatic disease. Virchow's node, that's a palpable, firm lymph node in the left supraclavicular fossa, indicating spread through the thoracic duct. There's the sign of Lézard-Trélat, the sudden, explosive onset of multiple seborrheic keratoses, those waxy skin lesions, which can be a paraneoplastic sign of underlying malignancy, including gastric cancer, and Trousseau syndrome, a migratory thrombophlebitis or superficial blood clots, indicating a hypercoagulable state associated with the cancer.
Histologically, how do we classify gastric cancer? Is there a standard system?
The most widely used classification system is the Laurin classification, which divides gastric adenocarcinoma into two main subtypes based on their growth patterns.
What are the two types?
There's the intestinal type and the diffuse type.
How do they differ?
The intestinal type tends to form distinct glands, similar to intestinal cancers. It's more common in older patients, often arises in the distal stomach, and is strongly associated with that H. pylori-driven pathway involving chronic gastritis, atrophy, and intestinal metaplasia. It's often preceded by these pre-malignant changes.
And the diffuse type?
The diffuse type is generally more aggressive. It's characterized by poorly cohesive cancer cells that infiltrate diffusely throughout the stomach wall, rather than forming distinct glands or masses. It tends to occur in younger patients, can arise anywhere but maybe more often proximally, and its incidence seems to be increasing relative to the intestinal type.
Is it linked to H. pylori too?
Less strongly than the intestinal type. Diffuse type gastric cancer is often associated with specific genetic changes, particularly the loss of function of the E-cadherin gene, CDH1, which helps cells stick together. This loss of adhesion allows the cells to infiltrate widely.
Is this the type that causes that leather bottle stomach appearance?
Yes. Classically, the diffuse type is responsible for linitis plastica, where the entire stomach wall becomes thickened, rigid, and non-distensible due to the widespread infiltration of cancer cells. It carries a very poor prognosis.
Now, if we're lucky enough to catch gastric cancer very early, specifically when it's confined to the innermost layers, T1 tumors, can it be treated endoscopically?
Yes. For carefully selected early gastric cancers, endoscopic resection is a viable, curative, and minimally invasive treatment option. This avoids the need for major surgery like gastrectomy.
What are the techniques,
Well,
EMR and ESD?
Correct. Endoscopic mucosal resection, EMR, involved lifting the lesion and removing it with a snare. Endoscopic submucosal bisection, ESD, is a more advanced technique where the lesion is meticulously dissected away from the underlying submucosa using specialized knives.
Is one preferred over the other?
ESD is generally preferred for most early gastric cancers, especially larger ones, because it has a much higher rate of achieving an en bloc resection, removing the entire tumor in one intact piece. This allows for more accurate pathological staging and has lower recurrence rates compared to piecemeal EMR.
But not all T1 tumors are suitable for endoscopic resection, right? There must be strict criteria.
Extremely strict criteria. The absolute criteria generally include: the tumor size should be small, typically luval $20 for certain types. It must be histologically well differentiated, usually the intestinal type. It must be confined to the mucosa or only minimal submucosal invasion, $500 microns. And critically, there must be absolutely no evidence of ulceration within the lesion and no lymphovascular invasion seen on pathology.
So very specific conditions. And even after a successful endoscopic resection, is H. pylori treatment still important?
Absolutely critical. Even if the primary cancer is completely removed endoscopically, eradicating H. pylori significantly reduces the risk of developing a new, separate gastric cancer later on, what we call metachronous cancer. So H. pylori eradication is standard practice after endoscopic resection.
We mentioned the diffuse type of gastric cancer, and it's linked to genetics. There's a specific hereditary syndrome associated with this, right? Hereditary diffuse gastric cancer, HDGC.
Yes, HDGC is a distinct inherited cancer predisposition syndrome. It's defined by specific family history criteria. For example, having 2 or more cases of diffuse type gastric cancer in first or second degree relatives, with at least one diagnosed before the age of 50, or having 3 or more cases at any age.
And it's caused by a specific gene mutation.
Primarily, yes. It's an autosomal dominant condition, meaning just one copy of the mutated gene is enough. The main culprit gene is CDH1, which encodes the E-cadherin protein we mentioned earlier, crucial for cell adhesion. Germline mutations in CDH1 lead to this syndrome.
And the risk associated with carrying that mutation is extremely high.
Exceptionally high penetrance. For individuals with a pathogenic CDH1 mutation, the cumulative lifetime risk of developing diffuse gastric cancer is estimated to be somewhere between 67% and 83% by age 80 for women, and slightly lower but still very high for men.
Wow. With risks that high, what's the recommended management?
Given the insidious nature of diffuse gastric cancer, it's hard to detect early with endoscopy because it infiltrates under the surface, and the extremely high lifetime risk, the standard recommendation for individuals confirmed to carry a pathogenic CDH1 mutation is prophylactic total gastrectomy.
Removing the entire stomach preventatively.
Correct. Usually recommended between the ages of 20 and 40 before cancer has a chance to develop. It's obviously a major life-altering surgery, but it's considered the most effective way to prevent this almost inevitable cancer.
What if someone declines surgery or is too young? Is surveillance an option?
Endoscopic surveillance, typically with annual high-quality EGD using specific protocols like the Cambridge Protocol, multiple biopsies every few centimeters, is considered an alternative for those who refuse or delay surgery. However, its effectiveness in detecting diffuse cancer at a curable stage is uncertain and generally considered inferior to prophylactic gastrectomy.
Is there any other cancer risk associated with HTGC we need to know about?
Yes, a crucial one, particularly for women. Women with pathogenic CDH1 mutations also have a significantly increased lifetime risk of developing lobular breast cancer, another cancer type associated with E-cadherin dysfunction.
So they need breast cancer screening too.
Absolutely. Intensive breast cancer screening, typically starting around age 30 or 35, involving annual mammography and breast MRI, is strongly recommended for women with HTGC.
Let's shift from adenocarcinoma to another type of gastric malignancy, gastric lymphoma.
Gastric lymphoma is actually the most common site for lymphoma to arise outside of the lymph nodes themselves, what we call extranodal non-Hodgkin's lymphoma.
And it usually arises from specific tissue in the stomach lining.
Yes, most gastric lymphomas arise from the mucosa-associated lymphoid tissue, or MALT. This is lymphoid tissue that develops in the stomach lining, usually as a response to chronic inflammation, most commonly.
H. pylori again.
H. pylori again. Chronic H. pylori infection is the major driver for the development of gastric MALT lymphoma.
What are the main subtypes of gastric lymphoma?
Broadly, we divide them into low-grade MALT lymphoma, also called marginal zone B-cell lymphoma of MALT type, or dysmaltoma, and more aggressive high-grade lymphomas, most commonly diffuse large B-cell lymphoma, DLBCL, which can sometimes arise from a pre-existing meltoma or occur novo.
Now, the connection between H. pylori and the low-grade meltoma is truly remarkable, isn't it, in terms of treatment?
It's one of the most stunning examples of curative antibiotic therapy in oncology. For patients diagnosed with stage I1 gastric meltoma, meaning it's confined just to the stomach wall, that is confirmed to be H. pylori positive.
What happens if you just treat the H. pylori?
Simple eradication of the H. pylori infection using standard antibiotic regimens like the bismuth quadruple therapy we discussed leads to complete and durable regression, essentially a cure of the lymphoma, in a remarkable 75% to 80% of cases.
Without needing chemotherapy or radiation?
Without needing chemo or radiation, exactly. The lymphoma essentially melts away once the chronic antigenic stimulation from H. pylori is removed. It's incredible. Follow-up endoscopy is crucial to confirm remission, though.
What if the meltoma is H. pylori negative? Or if it doesn't respond to eradication? Or what about the more aggressive DLBCL type?
For H. pylori negative meltoma, or meltoma that persists or progresses after eradication, the standard treatment is usually localized radiation therapy to the stomach, which is highly effective. For the more aggressive diffuse large B-cell lymphoma, or for more advanced stage meltoma, systemic chemotherapy, typically with regimens like RCHOP, rituximab plus CHOP chemotherapy, is the standard of care, similar to how nodal DLBCL is treated.
How is gastric lymphoma staged? Is it the same as other lymphomas?
It uses a specific staging system, most commonly the Lugano staging system, which is adapted for gastrointestinal lymphomas. It focuses on the depth of invasion into the stomach wall and involvement of nearby lymph nodes or distant sites. One key difference is that the Lugano system effectively omits stage 3, going directly from stage 2, regional node involvement, to stage 4, disseminated disease.
Okay, to wrap up our deep dive into the stomach, let's finish with a true acute surgical emergency. Gastric volvulus.
Gastric volvulus. This is when the stomach twists abnormally upon itself, leading to obstruction and potentially cutting off its own blood supply.
Does it twist in a specific way?
It usually twists along one of two main axes. Organoaxial volvulus is rotation along the long axis of the stomach, from the cardia to the pylorus. This is more common and often associated with large paraesophageal hernias that allow the stomach to rotate up into the chest. The other type is mesenteroaxial volvulus, which is rotation along the short axis perpendicular to the long axis. This is less common and sometimes associated with abnormalities of the ligaments that hold the stomach in place, or even splenic abnormalities.
And the danger is the degree of twisting.
Exactly. If the stomach twists more than 180 degrees, it creates a closed loop obstruction. This can rapidly lead to strangulation, cutting off the blood supply, resulting in ischemia, necrosis, and perforation. It's a catastrophe if not recognized and treated quickly.
Is there a classic clinical presentation we should look for in the emergency department?
Yes, there's a classic triad of symptoms known as Borchart's triad. Recognizing this is potentially life-saving.
What are the three components?
1. Severe sudden onset epigastric or chest pain. 2. Retching, usually unproductive, meaning they're trying to vomit, but little or nothing comes up because the esophagus is blocked by the twist. And the third, really critical sign, the inability to pass a nasogastric NG tube. The tubes simply won't advance into the stomach because the twist at the gastroesophageal junction blocks its path.
So seeing the triad should trigger immediate action.
Immediate surgical consultation. An acute gastric volvulus is a surgical emergency. The treatment is urgent surgical exploration to untwist, reduce the stomach, assess its viability, and usually perform a gastropexy, tacking the stomach down to the abdominal wall to prevent it from twisting again.
Can endoscopy play any role?
Endoscopy, EGD, can sometimes be used for diagnosis if the clinical picture is unclear, as it can directly visualize the twisted anatomy. In some cases, if caught very early and ischemia or perforation is confidently ruled out, careful endoscopic decompression and untwisting might be attempted by a skilled endoscopist. But surgery remains the definitive management for acute volvulus, and time is absolutely critical.
We have covered an incredible amount of ground today, from the intricacies of managing a stomach that's too slow or too active, navigating the huge shifts in dyspepsia diagnosis,
to understanding the central role of H. pylori in everything from ulcers to malt lymphoma to the gastric cancer cascade itself.
the key takeaways really stand out.
And the careful, constrained use of metoclopramide for gastroparesis due to the TD risk, with GPM reserved only for the truly refractory, plus the absolute necessity of 14-day bismuth quad therapy first line for H. pylori and confirming eradication 4 weeks later with an active test.
These are concrete, actionable points. But this deep dive also really highlighted those gray areas, didn't it? Particularly the controversy around surveilling gastric intestinal metaplasia.
It really did. You have major European guidelines strongly recommending surveillance based on the potential to detect early cancer versus the current US AGA guidelines recommending against routine surveillance due to lack of proven mortality benefit in our population. A direct conflict.
And that conflict leaves us, and importantly you, the listener, whether you're a clinician or just deeply interested in this, with a final, quite provocative thought to mull over.
When the scientific data provides uncertain evidence about whether an intervention, like IM surveillance, actually saves lives, how do we balance that population-level uncertainty against the incredibly high value an individual patient might place on doing everything possible to prevent cancer?
How do we navigate that conversation? Where does shared decision-making fit when the evidence is ambiguous but the stakes feel enormous to the person sitting in front of you?
That intersection of scientific uncertainty, differing guideline interpretations, and deeply held personal values, that's the real deep dive, isn't it? Learning how to manage that uncertainty is central to the art of medicine.
A perfect place to leave it for today. Thanks for joining us on the deep dive.
Thank you.